Welcome to our echo session for today. Go ahead and go to the next slide, Melissa. So our didactic presentation will be on harm reduction and syringe services in Tennessee today by the Tennessee Department of Health's in the syndemic coordination team. We will have a case presentation, a session for Q&A, and then closing remarks. My name is Lindsay. I will be filling in for Mia or Shamia today. As a reminder, for the continuing education credits, you do need to register for this session. You can click on the QR code, or you can visit the link here through the SEAETC. The link is also in the chat for registration as well. Next slide. A few introductions and announcements. Please put your information in the chat to include your name, your title or role, the organization you represent, and then also if this is your first echo session. I'll give everyone just a couple of seconds to put that in there. If you have at any point any technical difficulties during this session, please reach out to Anastasia Cahigal, and she can help with any technical issues. So I think we see several repeat attendees, but I think I do see a couple of new ones maybe. All right, we'll go ahead and go to the next slide, Melissa. And I am going to pass it over to Rebecca Amatia, who is going to be our presenter today from the in the syndemic coordination team regarding harm reduction and syringe services.
Thank you, Lindsay. Let me get my screen going here for you all. And I'm also joined by my colleague, Anastasia Cahigal, and I'm actually going to turn it over to her to start us off. Anastasia.
Cool. Thank you both, Lindsay and Rebecca. Hi, everyone. My name is Anastasia Cahigal, and I serve as the Syndemic Special Projects Coordinator at the Tennessee Department of Health, and we sit under the Syndemic Coordination Program, which is adjacent to HIV, STI, and viral hepatitis programs. So thank you to the Viral Hepatitis Project ECHO team. I'm joined today by Dr. Rebecca Amatia, who's the Director of Harm Reduction Initiatives, and together we make up the Syringe Services Program team at the Tennessee Department of Health. Next slide, please. And as usual, we would like this presentation to be a little interactive, so we will be using Menti, but you can feel free to use the Zoom chat or the unmute button to ask questions at any time. And the Menti link is also in the chat for everyone. So I'll just give it a little mini echo pause while people sign in. Awesome. Thank you for the thumbs up as well. Okay, we can go to the next slide. So as the Syringe Services Program, or SSP team, we support emerging and existing SSPs throughout Tennessee by overseeing the SSP applications, providing technical assistance, conducting community presentations like this one, and building a community of practice across the state with our agencies. And to provide even more comprehensive support to SSPs, we also collaborate with various programs throughout the Department of Health, like our viral hepatitis program, and we also collaborate with the Department of Mental Health and Substance Abuse Services. Next slide, please. So, as you know, today we're here to talk about harm reduction and syringe service programs in Tennessee. We'll also talk a little bit about our current Tennessee landscape and drug use stigma. Next slide. So, like I said, we wanted to be a little bit interactive. So before we dive deep into the content, we want to know about your current understanding and thoughts regarding harm reduction. So what does harm reduction mean to you? You can use the Menti, you can use the chat, you can unmute if you'd like. I don't know is also an acceptable answer, although I know Dr. Allen covered harm reduction in a previous ECHO session. Okay, so we've got a couple answers. Meeting people where they are, supportive care, healthy people, autonomy and compassion for people who use drugs. Autonomy is a really good word. Meeting a person where they are to assist with their needs, education, supportive care, preventative. These are all very good words. Protecting people from communicable diseases while providing resources. Meeting people where they're at by providing services to eliminate the potential of spreading viruses, reducing stigma, reducing the risk of contracting BBP, bloodborne pathogens. Rebecca, are there any more at the bottom? Okay. Educating individuals, enabling them to prevent self-harm. Cool. Thank you, everyone. Next slide, please. So, like I said, those were, thank you for sharing all of your definitions of harm reduction. For this training, we will use the definition that harm reduction is a practical approach that incorporates community-driven public health strategies to empower people who use drugs with the choice to live healthy and self-directed lives. It emphasizes directly engaging with people who use drugs to prevent overdose and infectious disease transmission, improve physical, mental, and social well-being, and offer low-barrier options for accessing healthcare services. And we know that most people who use drugs do not develop habitual or chaotic drug use. Harm reduction understands drug use as a complex continuum of behaviors, and it acknowledges that some ways of using drugs are clearly safer than others. We also know that harm reduction is a movement rooted in drug user health and liberation. It acknowledges that racism, stigma, and criminalization cause and perpetuate the harms that people who use drugs face. Harm reductionists practice radical empathy and neutrality, allowing the client to take ownership over their health and treating them with respect. So that's that autonomy piece that someone mentioned. It's also important to recognize that healthcare might not be someone's immediate priority, especially if they're grappling with other issues like housing or food insecurity. So it's important to affirm their participation in services and acknowledge that they're doing the work to address their health issues, however they can. So next slide, please. So syringe services programs, or SSPs as I'll frequently use, they're evidence-based public health programs that provide low-barrier comprehensive harm reduction services. This includes access to and disposal of sterile syringes and injection equipment, naloxone and overdose prevention education, infectious disease testing like HIV and hepatitis C testing, linkage to infectious disease, substance use disorder, and mental health care, and linkage to other supportive services like housing assistance. SSPs provide their services in an environment that presents as few barriers to clients as possible. So this is like a convenient location, anonymous services, accommodating hours. And the goal is to meet the client where they are and to offer wraparound services that are ready when the client needs them. Next slide. The use of opioids and other substances has been linked to increased transmission of HIV, hepatitis C, and STIs like syphilis. HIV and hepatitis C can be transmitted through sex or the sharing of needles, syringes, and other supplies used to inject drugs, which is why it's important to provide sterile equipment to those who use drugs and to discourage needle sharing. Next slide, please. So harm reduction finds its roots and inspiration across multiple movements and strategies emerging across the United States in the 60s, 70s, and 80s. We see this through the Black Panther Party survival programs with their free breakfast for children and their free health clinics. And then we see United States SSPs start to emerge in the 80s as grassroots and activist response to the HIV crisis and the lack of response from government and healthcare. Also, we know that the CDC knew as early as 1983 1983 that those who inject drugs were highly vulnerable to HIV and hepatitis C transmission through needle sharing. Then in the late 90s, we start to see an increase in overdose deaths due to prescription opioids. Next slide, please. In 1998, the scientific evidence in support of syringe exchange was sufficiently compelling that the Secretary of Health and Human Services made the finding that syringe service programs were safe and effective. In 2010, we see a concerning increase in overdose deaths due to extreme policy response to prescription opioids and people starting to turn to heroin for pain medication. Then we see fentanyl and stimulants saturate the street market, leading to even more overdose deaths starting in 2014, 2015. However, we also start to see more harm reduction forward efforts implemented across the U.S. with an increase of syringe service programs nationally. But it wasn't until 2015 when we really start to see SSPs become more widely accepted, especially at the government level and within the healthcare and public health system. This was in response to a concerning HIV and hepatitis C outbreak in a small rural town in Scott County, Indiana. Next slide. So why is harm reduction relevant in Tennessee? We talked about how syringe service programs sort of offer those wraparound services that address HIV, hepatitis C, substance use disorder, STIs, all of the things. This map demonstrates the level of syndemic impact based on the number of conditions each county ranks among the top 15 in 2021, which is a little confusing, but for example, if we focus on Cobb County, which is the one that the arrow is sort of pointing away from, there's a high syndemic burden with some of the highest rates across viral hepatitis A, B, and C, syphilis, and fatal overdose in Tennessee. So we know that SSPs address all of these sorts of conditions and are most needed in areas like Cobb County. Next slide. There's been over 30 years of research that demonstrates the effectiveness of SSPs and their life-saving abilities. These programs create positive healthcare engagement for people who use drugs by providing non-judgmental and accessible services. It leads to building trust where the clients can return to the SSP and get other services related to their health and their life when they're ready. SSPs are an effective HIV and hepatitis C status neutral strategy beyond sterile needle and syringe distribution. Because SSPs are associated with an estimated 50% reduction in HIV and hepatitis C incidence from providing sterile equipment, disposal of that equipment, and acting as a bridge to health services such as testing, prevention services like PrEP, and hepatitis C and HIV treatment. Next slide. So understanding all of those benefits, the increasing impact of the opioid crisis and the growing impact of hepatitis C and HIV outbreaks, SSPs were signed into Tennessee law in 2017 with various amendments throughout the years. And now non-governmental organizations and local health departments can apply to operate an SSP. In Tennessee, an organization must submit an application to the Department of Health, which is Rebecca and I, and it will be reviewed by us and approved by our Commissioner of Health prior to operations. Also, the law states that SSPs must operate at least 1,000 feet from a school or public park. However, there's an exception for those who want to operate in Kingsport must be at least 2,000 feet from a school or park. And lastly, the SSP law lists what services SSPs must directly provide, such as free sterile syringes and other injection equipment. There's also some indirect services, such as referral and linkage to healthcare services. Next slide, please. Since they became legal to operate in Tennessee, we've seen an increase in operations. We now have 15 agencies and I think we have 34 sites as of last week, providing syringe services throughout Tennessee. And we have an up-to-date list of our SSP locations and operational details on our website. There's a link on the slide or QR code. Next slide, please. And every year we release an SSP annual report. Last year's report highlights TDH HIV prevention funded SSPs, which is just a small snapshot of all of our SSPs. In 2022, over 1,600 rapid HIV tests and over 1,100 hepatitis C rapid tests were conducted. All SSP participants with an antibody-positive hepatitis C test are referred to confirmatory testing, usually to a local health department or a trusted provider. And additionally, SSP staff also provide linkage to hepatitis C treatment services and provide ongoing encouragement for HCV treatment. If you want to learn more, you can access the report through the QR code, or we have the report on our website. I'll also drop a link in the chat, and we'll soon be compiling data for the 2023 report. Okay, so I know I said a lot. Just wanted a quick echo pause to see if anyone had any questions, and I can also check the chat. Echo pause, echo pause. Okay.
Hey, Anastasia, I do
Yes.
have a question.
Mhm.
What, I saw the population restrictions
Mhm.
with Kingsport being given the example.
Yes.
Is that what's like makes Kingsport so special, I guess, aside from other communities across the state?
Rebecca, do you want to answer
Yeah,
that?
I can answer that. So this is a newer amendment that happened and took place in 2023, and there was a lot of legislators who discussed this. And so originally this was supposed to be for all of Tennessee, because prior to 2023, the restriction was 2,000 feet for anywhere outside of a metro. And so this was really to even that playing field and make it more accessible in our rural areas. But during kind of the legislative part of this, the Kingsport legislators really moved to try and keep it to that 2,000 feet with an amendment to the amendment, and they were successful in that. So that's kind of where we're at today, which we'll get into some of the reasons potentially why in the next few slides as well.
Thank you. There
Yeah,
is
of
a
course.
question in the chat. Is the 1,000 feet from school does it include universities and colleges?
It does not.
Okay. And then someone else also commented, I thought the previous law prevented state entities such as TDH from having SSPs. Did that get amended?
No, so it's non-governmental organizations, and then there was an amendment in 2018 that allows local health departments to have an SSP, which we don't currently have at this time, but is a priority we are looking into. Any other questions? Well, thanks, Anastasia, for giving kind of the background and landscape within Tennessee, and kind of also why we're here today, and what some of you already brought up in that open response about stigma, of why harm reduction and SSPs are important, and some really key things to remember when working and providing services to people who use drugs, and that is that they experience unique barriers to healthcare access. Drug use stigma is the negative and unfair beliefs and attitudes towards people who use drugs, and this has been identified as a major contributor to healthcare disparities and inequities for people who use drugs. So stigma really creates that social conditions that make people who use drugs believe that they're not deserving of being treated with dignity and respect, and it really perpetuates feelings of fear and isolation. And we see drug use stigma at various levels, from what we call as structural stigma, which is our policies, to community and organizational stigma among, within our neighborhoods, our providers, and then the individual level where we see internalized stigma. So today we're just going to briefly focus on just a couple examples of structural stigma, and then a little bit more provider level stigma and its impacts on people who use drugs and access to their healthcare. Yes. Okay. So starting with that structural level, so really looking at the larger political and institutional beliefs, and that impacts policy and funding. So for example, the underfunding or restriction on funding for evidence-based services like harm reduction and medicated therapies like MOUD, buprenorphine, these restrictions on funding really mean that people face greater barriers to accessing appropriate care for substance use. There also used to be restrictions on hepatitis C treatment as well for people who use drugs. And so this really prioritizes only one method for safer drug use and health for people who use drugs, which is abstinence and recovery. And studies show that society overall looks more favorably on those who are in recovery. For example, housing assistant programs have an abstinence from drugs requirement often, or including not being on any medicated assistant therapies or MOUD. But we know that stable housing, regardless of drug use, is key to an individual's health journey, including their substance use treatment as well. Another example at this policy level is enacting laws that are more punitive, which we start to see more and more recently, rather than really focused on those public health strategies that we know are effective and evidence-based, such as we see harsher punishments for some drugs over others that are really rooted in racism and create racial inequities in access to drug use healthcare. So research and people who use drugs have said over and over and have highlighted that many providers hold negative attitudes and beliefs about their patients who use drugs. And this really influences how care is provided to them. Patients might not be told all of their options for healthcare, treatment, or prevention. Patients might be discouraged from certain options because the provider has a belief that the person who used drugs can't adhere to the care, which we know that there's no difference between the general population and people who use drugs in care adherence or medication adherence, and that there's often other barriers that really get in the way. Patients are denied services altogether and often referred places like emergency rooms when seeking non-emergency care. Provider-based stigma then can really go into that internalized stigma, so causing a loss of self-worth and dignity for the person who used drugs. It leads to clients not receiving the proper care that they need, and it really starts to build that lack of trust within the medical system, thereby impacting future use of needed services, either discontinuing their care or delaying care until it's a state of emergency, which we know is more costly both to our healthcare system as well as the patient. And then lastly, I think we all know stigma increases morbidity and mortality for people who use drugs, even though many health issues are preventable or treatable. So really quickly, we're not going to get dive deep into this needs assessment, but in 2022, we did conduct a syndemic needs assessment, looking at really trying to identify the gaps and barriers in prevention and treatment access across HIV, STIs, substance use, and viral hepatitis. And so this was really to better understand what those gaps and barriers were. This was a mixed method approach, so we did have a statewide survey, and then we also did qualitative with focus groups and key informant interviews to kind of provide more of those nuanced understandings in priority populations. You can access this report on the QR code, and we can put a link in the chat as well. But I'm mentioning this today because the needs assessment, we really included a focus on people who use drugs and their needs and access to prevention care services across those syndemic conditions. So I'm just going to quickly highlight some of that data just to give some additional, some additional insights within Tennessee, what Tennesseans are experiencing. So on this slide, really quickly, this figure demonstrates the needed services and the disparities in access to those needed services among respondents who indicated drug use. The green bars here represent the number of respondents who needed each service, and then the purple line represents that disparity in access, and that's just demonstrated as the percent of unmet needs. So those who needed the service and were unable to access it. And so, for example, I wanted to highlight, which we saw kind of different than our general population, was that hepatitis C treatment wasn't necessarily the top needed service, but it was a pretty needed service by almost 30% of respondents who use drugs, and almost over 45% were unable to access treatment. Additionally, we can see inpatient substance use disorder treatment and counseling were higher needs and also had high unmet needs. We did ask barriers to accessing services, so why they weren't able to get the service that they felt they needed. And for people who use drugs, the top reason for not being able to access hepatitis C treatment was discrimination and stigma. Then it was also about concerns about cost and then not knowing where to get services, but this often was in conjunction with not really knowing of a trusted provider, and then no health insurance, so again, about the cost, and then that intersection of experiencing homelessness. Additionally, we did that qualitative part, and what also came up in qualitative and our qualitative methods was stigma and discrimination. So having to constantly advocate for yourself, if you're even able to do that. So they did recognize that a lot of people aren't, and that's a huge barrier to accessing healthcare services, of either having had experienced it already in the healthcare system or fear of experiencing stigma and being discriminated against. They did mention how reducing stigma through inclusive language is really helpful. Having harm reduction approaches and providers having trauma-informed training was really helpful. We did talk about barriers. So one of the top barriers in regards to testing is that a lot of people say they already know they have it. And so that's a great opportunity to have education about hepatitis C and the importance of testing and treatment. And then when it came to treatment, a lot of the barriers were around that sobriety restriction that used to be there in, I believe, 10 care, where they had to be sober. And so that belief is still within the community as well, and really can pose a big barrier to getting treatment. As well as if you look at that intersection again of homelessness, medication storage is difficult, and then losing their medication during citywide sweeps of encampments. But they did talk about things that have been helpful, so that compassionate education, so being transparent and honest, but not using fear-based strategies, so really helping people to understand their health condition, having safe and private spaces, low barrier options, and again, that trusted and non-judgmental service, being treated with respect and dignity. Oops, sorry. So here again, we wanted to stop if we have time and do another activity. Again, we're talking about stigma and reducing stigma. And so we often hear people say, you know, I was told because I use drugs, I can't get hepatitis C treatment. And I want to know how you might respond to this client if you heard someone say this to you or maybe overheard. And you can use the chat, unmute if you're able to unmute, or use the Menti. Okay, so the one that we have is treatment options are available. Let's talk about some of those. Yeah. Acknowledging that that used to be the case, but restrictions were lifted, so you're eligible now. Great. Yeah. Yeah, I really like this one. Like, you can be cured of hepatitis C regardless of your drug use. So that kind of acknowledges that it's okay that they're using, you know, that they can still get the services that they need regardless of their drug use. Yeah, and then also just being able to talk about, let's talk about your hepatitis C treatment options, but also maybe some other options that might be helpful to you. Great.
Also got a
Yes.
couple in the chat, Rebecca.
Yeah, I'm seeing that now. Thanks. We see, I had a client that said this recently, and I told her that was no longer true and sent her a list of current providers and info on SSPs. Great, thank you, Rebecca. Another one, I think it would be helpful to let people know that the policies have changed. Yeah. Great, so we'll move on. I think another important thing for you know, being providers is it's our responsibility to also break that stigma around among our colleagues as well. And so just thinking about how you might respond if you overheard someone, whether it's a friend, family, colleague, that says drug addicts are not able to complete their hepatitis C treatment. How could you respond to that person and help break down the stigma? And I will also challenge you here a little too with harm reduction is about meeting people where they are. So thinking about this person who made the statement, how could you meet them where they are, but also reduce stigma by, you know, not not acknowledging that they're incorrect, or not acknowledging that they're correct, but how might you interrupt this? People who use drugs care about their health. It depends on the patient. There is evidence showing that individuals using drug adhere to treatment regimens and obtain high cure rates. Yeah. Lots of research that shows a hepatitis C treatment is effective even if patient is currently in active substance use. Great. What tools or things can we do to support you in taking daily medication? Yeah, I like that. So if you're talking with the client, you know, helping to empower them in their own healthcare and ways that you might be able to help support them. I like this, you know, kind of calling out, calling in of why do you say that? Let's talk about your concerns and really trying to dig a little bit deeper. People experience different barriers. That doesn't mean they are hopeless.
Rebecca, there's also a comment in the chat that there are resources we can provide to help them complete their treatment and make them healthier for their future.
Great. Yeah, I love that. Great. Thank you for participating, everyone. So we're at the end of this presentation. I'm sure I talk a lot. But we did want to leave you with this one quote that we heard from someone who uses drug in Tennessee. Something they said about what they wish that their community understood. And that was that most people, if they took the time to speak to, they're just as nice as your neighbor next door. They may have a drug issue, and a lot of people do, but they're still human. They still need human contact. They need kindness, and they need just a little support, or just a kind word makes all the difference. Just don't judge. Also, I wanted to say this is a really quick presentation. We do a more in-depth harm reduction training. I believe the next one is in June. These happen quarterly, and this really is focusing on drug user health, and is for providers across the syndemic fields and anyone who's interested in learning more about harm reduction on a deeper level. We also have other additional resources, which I believe are on the Echo platform, this brochure. And then I just wanted to end with our amazing director, Syndemic Coordination Director, Amber Coyne, created this language guide with community, and that language really can be such a strong tool to really reduce stigma. And so really recommend reviewing this language guide. She also does trainings, so you can reach out to her at amber.coyne@tn.gov if you do want to do a language guide training. But in this guide, how it's set up is it has try this instead of this. And then it kind of gives a little explanation and education why the change in language and the importance of it. And that is all for us today. Thank you for having us. We really enjoyed the opportunity to speak with you all. And thank you for your engagement in our presentation today.
Thank you so much, Rebecca and Anastasia. Your team does a lot of great work, and it's very much appreciated. One thing I just wanted to touch on when you posted the comment in the Menti chat about individuals not completing their Hep C treatment just because they may use drugs. You know, I think one thing that's should be said about providers is we should never assume what a patient will or will not do based on their current living situation and circumstances. I think it's just in our best interest to encourage, build that trust, and ultimately they will make the decision, hopefully with encouragement and the relationship that we have with them, to continue their treatment. But it's definitely not our position to judge or assume.
Yeah,
Melissa,
exactly.
I'm sorry, go ahead.
Oh, no, exactly. Thank you for adding that.
I did want to mention that someone else added in the chat, they are human beings just like everyone else is. And I think we can all agree on that.